Thomas Braunsteiner from Austria to speak about Pipkin fractures. The speaking time is between 15 to 20 minutes. As shorter the time, as longer the discussion, hopefully. Thomas.
Thank you, Mr. Chairman, ladies and gentlemen. First, some remarks about the hip joint, because this is the first lecture. The hip joint is the greatest and most stable joint of the human body. It is able to do multi-axial movement. It's a ball and socket type of joint. The range of motion is quite big, as you see, in all directions. During the movement of the hip joint, about 40% of the femoral head is in contact with the acetabular cartilage, and 10% more with the labrum, which is a plastic cartilage structure around the head. The labrum is a strong fibrous ring. It decreases the femoral head coverage and contributes to hip joint stability. The joint capsule itself is a very strong structure. It extends from the intertrochanteric ridge to the bony perimeter of the acetabulum, and inside the joint is the ligamentum teres, but it has no or very little influence on the stability of the joint. The femoral neck has an anteversion. It's usually in the Caucasian males about 7 degrees. It is slightly higher in females. It's interesting that in Oriental males and females it is higher, about 14 to 16 degrees. The reason is difficult to say, perhaps sitting on the floor question. The blood supply of the femoral head is given by ascending cervical branches. They arise from the arterial ring at the base of the neck. The ring is formed of branches of the medial and lateral circumflex femoral artery. The arteries penetrate the head in ascending branches, and they perforate the bone distally to the cartilage of the femoral head, and it is highly susceptible to injuries of the hip, dislocation or fracture. The next structure is the sciatic nerve, which is composed of roots from L4 to S3. The peroneal and tibial components can divide in the haze of the hip, or also more distally. It generally passes inferior to the piriformis muscle. It's very important because of the injury patterns and the access to the hip joint. The mechanism of injury in Pipkin fractures is a high energy impact on the flexed hip. It is a shear fracture. The acetabular rim cuts the head during the dislocation. The injury pattern depends also on the position of the leg, on the flexion, the degree of flexion, adduction, abduction. Less flexion is more damage, and more flexion is less damage. Nowadays, the dashboard injury is the most common cause of the hip dislocation and femoral head fracture. The first publication about dashboard injuries is from the year 1938, and it describes 20 people. Interesting that the right side is much more affected than the left. Absolutely, the first publication is from Birket from 1869. It was a fall from the haze from the second floor, and the fracture was discovered only at autopsy. Then other publications came, all about the hip dislocation, and you see here a publication of Armstrong with 101 cases, but only 5 cases were associated with femoral head fracture. They were described, and the outcome is very interesting because 2 are very good and 2 are bad. Then other publications are also found, 94, but these only case reports. Thompson and Epstein described the traumatic dislocation of the hip, and they found that the type 5 is a dislocation associated with femoral head fracture. Important in this work is that they did the first and perhaps the best classification of outcome, clinical and radiologic as well. Then Stewart and Milford described the fracture dislocation of the hip, and the grade 4 dislocation is associated with fracture of the neck or the head of the femur. They described two types, the so-called normal dislocation and the central dislocation. Based on this work, then Garrett Pipp made his fracture and therefore his work about the division of this grade 4 fracture dislocation, and since then this fracture is also called the Pipkin fracture. These are the original images of Pipkin of the type 1, the caudal of the fovea fracture, 1B, proximal of the fovea, then associated with neck fracture, and the fracture associated with rim fracture. The problem of the Pipkin classification is that it does not describe the lesion of the joint capsule and the labrum, which is very important because it is sometimes thought, and in these classifications, that the capsule is not damaged, but the capsule is very damaged. Then Brumback in 1986 made a new classification or extended classification where also slight impressions of the femoral head are described. It allows a more comprehensive evaluation, but for practical use, the Pipkin classification is now the leading. The AO classification describes very good the bone bruise and osteochondral impaction, but does not take into account the acetabular lesion. The diagnostics of Pipkin fracture is, first of all, the clinically shortened intra and extra rotated leg if the dislocation is present. On plain X-ray, we can have a suspicious image, but usually only the CT imaging technique, because we can describe the fracture type, we can describe where the different fragments are, what is the location, and very useful is the 3D reconstruction of the whole hip. After treatment, post-reduction or operation CT should be done, and the follow-ups by plain X-rays. The general aspects of treatment, because it is very often, and nowadays very often in the framework of polytrauma, is the ATLS protocol. It should be as early as possible closed reduction done. If it is not successful, early open reduction within 6 hours is recommended. In Pipkin 1 fractures, we usually prefer the conservative treatment. If it is not possible, then open reduction and internal fixation or excision of the fragment is also possible. If it is not possible to reduce, there is a buttonhole of the capsule, and therefore we have to open it, and usually we have to open it from a dorsal approach. This is a patient, 22-year-old male, posterior superior fracture dislocation of the hip, open reduction and fixation with titanium screws, like here in the postoperative CT. In Pipkin 2 fractures, again, conservative treatment can be successful, but there is more often the necessity of open reduction and internal fixation. Since it is a weight-bearing area of the femoral head, ever internal fixation is necessary. We cannot remove these fragments. And the ligaments must not be disconnected, because this is the blood supply for this fractured fragment. In this case, again, a 35-year-old male, conservative treatment was done. Despite of this big fragment, the reduction was possible, and we see on the post-reduction CT a good alignment. Pipkin's fractures are the most rare type of these injuries. The complication is avascular necrosis of the femoral head. It has a high incidence and depends on the measure of displacement, as well as on the biologic age of the patient. We have to do the reduction. Usually only an open reduction is possible. First of all, we have to fix the neck fracture and then the femoral head fracture. If it is a young patient, we have to do an open reduction internal fixation. In the elderly patient, primary total hip replacement is recommended. And Pipkin 4 fracture, it means femoral head and acetabulum. It is a hip emergency. It requires appropriate treatment of both fractures, femoral head and acetabulum. To reassess the hip stability is crucial. The difficulty here is that we see a small bony fragment, but as I told previously, the labrum is enhancing the fragment size, and therefore the instability is usually bigger than suspected from the bony fragment size. These cases are quite difficult in complex types of acetabulum fractures. Like in this case, we see a complex fracture with this fracture dislocation. Reduction internal fixation with a plate was done, but then the plate moved, the screws broke. Total hip was done, but it is also unstable, and we see that the acetabulum is also dislocating. The question is, in this case, perhaps the primary total hip would have been the more proper solution. Complications of this fracture are usually pain up to 90% in different studies, avascular necrosis of the femoral head, then osteoarthritis, heterotopic ossification, sciatic nerve lesion, primary or secondary, non-union or malunion of the femoral head, and chronic recurrent hip dislocation. All these complications are described. In a comprehensive study of NASTCO, 117 patients were analyzed, and we see that more complications are in the operative treatment group. The conservative group had less osteoarthritis or avascular necrosis, but the operative group has a lot of complications. In Vienna, we had 44 patients in the time gap of 1992 to 2009. The male-female ratio was 2:1. 16 patients were polytraumatized, and 8 patients had multiple fractures, one ipsilateral subtrochanteric and one ipsilateral femoral diaphysis fracture. And what's interesting, again, the right to left ratio is 2:1. So the right side is affected more than the left. An explanation for this I do not have. The type of injury, side and gender, we see that are more and the right side. The most rare case is again the Pipkin 3 fractures, which is only 5% of the whole group. What we did, conservative treatment in 19 cases was quite high, but if you do the reduction very early after the injury, it is possible. Then the screw fixation is the most frequent treatment method, and primary total hip in some cases, mainly in the Pipkin 4 group. The results, we see that 80% of this group were excellent and good, and only 20% fair or poor. But all Pipkin 3 fractures belong to this group. The conclusions, what should we do? Hip dislocation and Pipkin fracture is a hip emergency. That is very important to know, and we have to do the treatment very early. The diagnostics is that despite of plain X-rays, of proper plain X-rays, we see in a study of Epstein that up to 42% of the fractures are missed on the primary X-ray. It means that the CT and the 3D reconstruction is a very important tool in diagnostics. Which approach should be used? There is no evidence which is the preferred dorsal approach or a ventral approach. If closed reduction is not possible, it means the femoral head is in the buttonhole, then we have to have a dorsal approach. Best is the Kocher-Langenbeck approach. It is described that it has a high incidence of vascular necrosis, but the question is it because of the operation or is it because of the injury itself? In 1 and 2 type fractures, the anterior approach is also discussed. It is described that perhaps it can cause also further destruction of the blood supply. It's a question. The anterior approach has a higher incidence of heterotopic ossification. The surgical technique should be, if we do an osteocentesis or internal fixation, full-threaded titanium screws. They should be beneath the cartilage surface. Excellent results with biodegradable implants are also reported, but it is not widely used. And also a percutaneous technique of Pipkin 2 fracture treatment is described. The therapeutic measures, hip reduction must be done within 6 hours and or as soon as possible as the patient is able to undergo an operation. Skeletal traction for 6 weeks leads to excellent and good results in 80% of cases. Nowadays, if the patient is cooperative, we can shorten this time. We can even do a very early mobilization, but it needs really a very cooperative patient. Nowadays, the patients require more and more the surgical treatment because they want to have a shorter immobilization time. Pipkin 3 fractures have the worst prognosis, that's clear, and there is no way how to reduce it, and perhaps we should go more to the total hip replacement primarily. In young patients, open reduction should be tried. If not, then secondarily a total hip should be done. And in elderly patients, the primary total hip is the of choice. In Pipkin 4 fractures, we have to do an open reduction of both fractures. We have to do a proper osteocentesis of the acetabulum and to achieve a good stability of the femoral head. If it is not possible, total hip is also one of the treatment measures. And in these cases also the acetabular fracture should be operated within the first 24 hours. What is the future outlook? Increasing security measures for car safety, mandatory use of seat belts and so on decreases the frequency of this occurrence. It means that the individual surgeon's experience is decreasing. Studies, what we can find, have a small number of patients, or they are comprehensive studies. The difficulty of comprehensive studies is that they have different criteria for follow-up, different inclusion and exclusion criteria, and that's a problem. There are no multi-center studies in the literature, and this is perhaps the future assignment, and we should try to organize multi-center studies to get more information. Thank you very much.
Thank you. The paper is now open for discussion. Are there any remarks? Of course, the fracture type is very seldom, but if you are confronted with that, it is really difficult to decide on what you are doing, as long the fracture is not reducible. So Mike would be, in my experience, and you told us that everybody has too small experience with this type of fractures, but in my experience, you can reduce the type Pipkin 1 and 2 coming from the posterior, but you cannot fix it. So you told us that the blood supply coming from the dorsal is negatively influenced, coming from the anterior is negatively influenced. What should we do?
In the literature, there are publications which describe that if we have to use the operative treatment and we have to open the capsule, we should use the GANS approach. It is an approach to the capsule which is saving the blood supply. But since tear in the capsule, I think this approach is not usable because you have an opening. You have to extend the opening that you find. And then the only possibility is to move the femoral head as good as possible and to do the osteocentesis. Usually if it is a distal infrafoveolar fracture, you can, if the osteocentesis is not possible, you can remove it. And the proximal fracture patterns, then you have a quite good access to the fragment. And also the fixation is, I think, easier than from the infrafoveolar fragments.
Yeah, that's the point. You can very nicely reduce, but you cannot use the drill bit. You cannot use a screwdriver coming from the posterior because the fragment is anterior. You can see it, you can reduce it, but you cannot fix it.
Yes, I told also that we have not to cut the ligamentum teres. If it is an infrafoveolar fracture and you have a dislocation, this ligament is already destroyed, then you sometimes have to re-dislocate the femoral head and so do the osteocentesis and then do the reduction. It's easier in the case that you have also acetabular posterior rim fracture. But it is very difficult because there are not enough experiences to tell a way how to do it. I think it is very individual and it is therefore needed that this operation is done by an experienced surgeon.
Are there any other questions, remarks from your side?
My question is, in type 3, you said you should fix the neck first, then the fragment. So how you fix the neck? With 2 screws, 1 screw? Because the level, there is a fracture in the head also. So which approach you use and how many screws you do?
Since it is a fracture and we have to do a osteocentesis, then the best is to use screws. If it is quite distal fracture, then sliding hip screw, a DHS, or some other.
Because your head is fractured, so you don't know the length of the screw. You can't use a C-arm because you are doing without a fracture table. These fractures can't be done in a C-arm fracture table. You are doing it without fracture table, so how will you put the screw? You will do open reduction posteriorly, then go interiorly.
You can do only open reduction because otherwise it's not possible to achieve a reduction of both of these fragments. The only access is an open one. The question is from dorsal or from ventral, or a lateral approach. That's the
we are doing from the posterior, then going for Gans extraotomy and doing anteriorly fixing the fracture.
Yes, this double approach I would like to avoid.
Gives you excellent view of the femoral head, and there's no injury to the vessel. The capsule tear is not there most of the time. Interiorly, there's no capsule tear.
I think a solution could be also the lateral approach, where you can get a good access also from ventral, also for dorsal. But the type of the neck fracture is the decisive what you should use.
Thank you.
So, the last question, or two, come down.
I think the anterior approach has a role. You cannot do always the Gans surgical dislocation, fix the fracture, and then fix the neck. In such a situation, if you go from the anterior approach, flex the hip and abduct the hip, then you can see the inferior part of the head of the femur which is broken. Fix it, and then as a whole you can do a DHS or screws for the neck of the femur. I think there's a paper by Dr. Sain from India, 50 cases, Pipkin's fracture. Dr. Samir might be knowing. And you could have cite that reference in your lecture from PGI Chandigarh.
I think if the neck and the head fragment are first fixed, then you have a limited possibility to use a fixation device between the femur and the proximal part of the femur, because you have some implants inside. So therefore it is recommended first to do the neck fixation and then the head.
In reality, I feel that you should improvise in every case something new. Only the principle is that leads me all the time to a relative acceptable success, fixing from anterior and reducing from posterior. And you should unite your brain in only one direction. That's my advice.
Therefore, it's also recommended in elderly patients to do primarily total hip because it's the solution. And in young patients, we try to do the osteocentesis only to avoid primary hip in a very young age. And if we can do an osteocentesis and we can postpone the total hip, I don't know, for 1, 2, 3 years, it's a win for the patient. And you have seen in all the studies where Pipkin's fractures are shown, the results are fair or poor. So it is an unsolved problem, I think.
So thank you very much, Tomáš. I ask now Gershon Volpin from Israel to give his talk, treatment of and outcome of surgical fixation of subcapital fractures of the femur by cannulated screws.
Mr. Chairman, thank you very much for inviting me to speak about it. Can I get the first one? So I want to present our experience with subcapital fractures and different methods of fixation. And there is still controversy in the literature regarding which method of treatment of intra-articular fracture is the ideal for such fractures of the femoral neck. Now, there are 3 methods that are commonly used. The first method is hip hemiarthroplasty, which is used to be once with the metal Thompson or Austin Moore monoblock prosthesis. In the last few years, the non-cemented bipolar came to use, and other reviews spoke about total hip arthroplasty in such condition. But there is another method which is classically used by many people to do open or closed reduction and internal fixation by either cannulated screw or other methods. So the idea to preserve the patient's own femoral head, if you can do it by successful internal fixations, seems to be the best solution for this type of hip fractures. In here we can see an old lady with fixation, preservation of both hips, done of course in different times. And you can pay attention that in one of the hip, the cannulated 3 screws are in configuration of 2 inferior and 1 above, and in the other one it is 2 superior and 1 inferior. And there is a great debate in the literature which configuration seems to be better. So, and this is the subject of this paper, which method of configuration screws seems to be better in such conditions. So we tried to evaluate the outcome and complication following fixation of such fractures with these cannulated screws. And the important factors that are to be discussed, of course, are the quality of reduction, the accuracy of the implant placement, the incidence of non-union, and the incidence of avascular osteonecrosis. So in this study, prospective study, we did two methods of triangular configuration, one superior and the successive one inferior, two superior and one inferior, and this was successfully one in this method and the other method. And we have here 112 intra-articular femoral neck fractures, subcapital, of 105 patients. 7 patients were bilateral. Mean age was 46 to 82. The mean age was 67 years. And the method is closed reduction, internal fixation by the cannulated screws with these two types of fixation. Now, the follow-up, during the follow-up, 12 patients were lost for follow-up, so we have now 93 patients in these 2 years. We total 98 hip fractures that were followed up to union or revision surgery, and you can see that the follow-up is between 1.5 to 4 years, about almost 2 years mean follow-up. Now, in the first group, there were 50, in this group, we had 52 patients with Garden 1 type fractures, 34 patients with Garden 2 fractures, 12 patients were with Garden 3 and 4. And all of these fractures were treated with the multiple hip. Now, in the first group of 1 superior and 2 inferior, we had 51 patients. In the other group, we had about 4 in the follow-up. While trying to see if there is any difference between the two groups of 1 superior or 1 inferior, there was not any statistic significant difference regarding age, sex, and type of the fracture according to Gardner classification between those two groups. And we assessed, have evaluated the quality of reduction, the accuracy of the implant placement, and the rates of non-union and avascular necrosis. And the result, in the 85% of the patients from both groups, we got a very good or either excellent reduction on the intraoperative X-rays. In 15 of them, the reduction was not so good. We'll describe it like fair or poor reduction was observed, and this is 15 patients in this group. The complication at follow-up, the rate of complication was about 14%. Non-union were seen in 8 patients. Avascular necrosis of the femoral head was observed in 6 patients, and we can see here the follow-up of beautiful reduction and development of non-union of the fracture, so it had to be changed to total hip later. But if we try to compare the results of this complication to the reduction, we could see that only 6% that had anatomical reduction, initial reduction, developed either avascular necrosis or non-union. But in 60%, 9 out of 16 patients, if the reduction was not good or anatomical, we could see development of this complication. So the first conclusion, of course, must be you have to do a very anatomical reduction and fixation. At follow-up, 6 patients, 4 with non-union and 2 with avascular necrosis were treated by revision to the surgery, total hip replacement. There were another 8 patients with this complication that didn't underwent surgery because of their poor general health condition and very low demands. There were not any deep infection. If comparing the functional outcome, we could see that in most of the patients there was some decrease in the rate of good functional result after this operation. 85 out of 93, the first patient had 91% of good functional outcome prior to fracture as compared to the 83%. Of course, this is because of the complication. So if we want to conclude it, we can say that excellent reduction and accurate implant placement are the main reason for a good outcome after closed reduction and internal fixation of intra-articular hip fractures. We didn't find any differences in patient outcome and complication rate following fixation in the 2 different configurations of these screws. Thank you very much.
Thank you again remarks, discussion? What I have missed, you are using the traction table for the closed reduction.
Sorry?
You are using the traction table for reduction of the
We're
fracture.
using the traction, but we don't do the traction. You see what I mean?
Yeah,
Where you put the patient on it, you fix the leg, and then you
But
can
you are
play.
not-
But
yeah.
you are not doing traction.
Is this mic on? Yes. I'm a bit confused. The majority of your patients had undisplaced or minimally displaced fractures in valgus, and still you talk about reduction. It would have been much more interesting if you have divided your material in undisplaced and displaced. I guess that the most of the complication is the displaced group.
I didn't hear him.
Yeah, I agree with him.
I didn't hear him, sorry.
You had only 12 patients in with Garden type 3, only 12.
Yes.
Yeah.
And your follow-up is just 1.4 years. I think it is too short a study for too short a duration of time to conclude anything.
Listen. Grade 1 is abducted type.
No.
So you don't need to do any.
no, the key what they both
I find the same.
gentlemen mean is
Yeah.
that the group which is more displaced, so Garden 3, is only a small amount in your
Yes,
study
that's what
group.
you have.
And therefore, the conclusion is very difficult to be made, since both have the opinion that the misleaded cases are these one
No.
who have been
Just to
more
remind you that
displaced.
we have also,
The results should
we
be
had also vascular necrosis and non-union in grade 1 and grade 2. I mentioned it. The amount of avascular necrosis and non-union increased in the grade 3 and 4. But we have also in grade 1 and 2 avascular necrosis. Therefore, you have to be sure about it.
There is no doubt that the undisplaced fracture in general have a necrosis rate around 20%.
Yes.
which is higher than in Garden 2 and higher than in Garden 3. So this has to do something with the pressure in the joint.
Yeah, but I think maybe I didn't stress it enough. You have grade 3 and grade 4, you do reduction. You get anatomical position. I said in many of these cases, as he said, as Professor said now, not only 20% of vascular necrosis or non-union complication. You get more than 3/4 of them, you get good functional result. In these cases that I present, even in grade 1 and grade 2, you can get about 10%, 8% of vascular necrosis and non-union. And not all the cases with grade 3 and grade 4 of completely displacement, you get a vascular necrosis and you get non-union. Therefore, even in young patient, the best thing is to do is try to preserve the femoral head. Don't go immediately, that's my opinion, don't go immediately to do replacement by Austin Moore, Stenmore, bipolar, total hip replacement, etc., etc. Try to preserve the head and follow your patient. In some of them, you have to go later to revision surgery. As I said, 8 of my patients had total hip replacement after the follow-up of them.
I just want to know that what was your sequence of putting compression, whether you put compression on screw on the superior side or inferior side. There should be some sequence.
I tried to put 2 different types of configuration. One, you have superior 1 screw, and the second one you have in the inferior part, you have 2 screws. If you open Rockwood, for example, in the book of Rockwood, preferred method, put 2 superiors and do the compression more from the superior side. I didn't find any difference between these 2 configurations, so I can give you more accurate reply.
So the last question.
What's the range of the age of the patients? I missed.
Sorry?
The age of the patients. Sorry, maybe I missed it.
67 in average.
And what's the range?
45 to 80 to 76, 77.
45, so young and middle age
yes.
and elderly. Okay.
Yeah. But
So
we didn't find any difference in these 2 groups.
Thank you very much. We are continuing to discuss femoral neck fractures. And I ask James Waddell to come up to the podium. He will discuss with us femoral head replacement or total hip replacement.
Thank you, Chairman. The table has been set for this discussion by the previous paper, and the issue, of course, is which operation is best for these patients. The Acta Orthopedica journal that you received when you signed in for this meeting contains within it an excellent review of fracture treatment in Sweden, which exactly parallels the experience of hip fracture treatment in North America. And excuse me, I'll try and show you over the next few minutes how the evolution of fracture care for subcapital fractures has evolved and now relies heavily on prosthetic replacement. This was termed the unsolved fracture almost 80 years ago, and this, of course, is the problem, the significantly displaced femoral neck fracture in the active adult. Now, surgical treatment consists of either excision, fixation, or replacement. Excision is rarely done now and is reserved for unique problems that we don't have to talk about today. Reduction and fixation, we know in displaced fractures that the reduction may be difficult, particularly to obtain an anatomican. The fixation may be unreliable, and in most series the complication rate is high and the reoperation rate in these fractures is high. Here's an example. Displaced subcapital fracture, Garden 3 or Garden 4. This is a patient of mine. And here's the intraoperative x-ray, which shows an anatomic reduction of this displaced femoral neck fracture. This is also an intraoperative x-ray showing the placement of the fixation with a posterior screw and an inferior screw as recommended by most authors who talk about this type of fracture care. And here's the result. 6 months later, avascular necrosis, non-union, screw back out, screw penetration. And this is an all too common outcome of reduction and fixation in this particular fracture group. And it's because of this, it's because of the uncertainty of outcome of this type of treatment that there's been increasing interest in the use of arthroplasty as a primary tool in the management of this fracture. Now, reduction and fixation is useful for minimally displaced or stable fractures, as we have just heard. It's a good operation with a relatively low complication rate and predictable outcome. There's increasing interest in the use of length stable versus sliding fixation for these fractures. That's not part of my talk, but I would suggest you look at this because there is some merit to using length stable fixation to improve the outcome in these patients. You maintain their femoral neck length, maintain adductor lever arm, and improve their gait. This is the type of fracture I'm talking about, a Garden 1 or impacted fracture, which we fixed with screws just to stop it from dissociating at 1 or 2 weeks after fracture and allowing the patient full active weight bearing immediately after fracture fixation, which of course is an important part of rehabilitation after proximal femoral fractures. However, in the displaced fracture, this type of fixation, as I've said, has unfortunately unreliable outcomes. So we think that this should be reserved in displaced fracture for younger patients under 60 years of age, but you have to remember that the complication rate is no lower in the young patients than it is in the elderly patients. So you shouldn't expect a lower rate of non-union or a rate of avascular necrosis in young patients, and you have to be prepared for this relatively high complication rate if you're going to treat displaced femoral neck fractures by reduction and fixation. So this debate is not about stable fractures, but about displaced fractures in patients greater than 65 years of age. So the question is, should these patients undergo primary reduction and fixation and only secondary arthroplasty if reduction and fixation fails? In other words, should we reduce and fix every displaced femoral neck fracture and then do a secondary operation for those that are unsuccessful? Should they undergo a primary arthroplasty without acetabular replacement, a monopolar, a modular monopolar, or a bipolar? And should this operation be done with or without methylmethacrylate? And finally, the third choice is a primary total hip replacement in this particular patient group. Well, let's look at primary reduction with subsequent revision arthroplasty. We know from the literature that the complication rate is higher in this particular group of patients than in patients undergoing primary total joint replacement, and we published a paper on this almost 10 years ago. The functional results may not be as good as in those patients that have a primary arthroplasty, as you can see in this reference. And this shows a not atypical appearance. You can see the residual screw from the failed internal fixation, cemented hip. Patient's done well, but the patient may have done better had they not had to have 2 operations for their hip fracture. What about primary arthroplasty without ATA replacement? Well, a monopolar with or without cement, our initial experience was with the Moore and the Thompson. Now, these implants have inferior results compared to modern designs. There's increased loosening without cement, with increased thigh pain in the Moore patient population, and increased acetabular wear with the cemented Thompson stem, resulting in disabling groin pain in a significant number of patients. So the recommendation is that this type of monopolar prosthesis should be reserved for very inactive patients. What about the modular monopolar bipolar that is more commonly in use today? Well, the modern stem design better replicates normal offset and leg length, so the function in these patients is better. And the modern stem design may allow better bone ingrowth for cementless stems, and the modularity allows for easier conversion to total hip replacement if acetabular wear becomes significant. However, there is good evidence in the literature that conversion of modular monopolar or bipolar to total hip replacement has a significantly higher complication rate than primary total hip replacement in femoral neck fractures. So what about the primary total hip replacement? Well, we know it gives good functional results with decreased pain, increased walking distance in these patients when compared to femoral head replacement alone. In other words, the total hip works better than the monopolar or bipolar. However, the surgery is associated with increased blood loss and increased dislocation rate as compared to the monopolar or bipolar prosthesis. Unfortunately, the literature does not give clear recommendations between these various options. Even randomized trials have not answered the question. There are definite trends, however, that may help us in making a decision for our patients. The surgical approach, there's no question that an anterolateral, posterior with or without repair, and modified posterior have all been used. There's definitely a decreased dislocation rate with the anterolateral and modified posterior approach compared to the standard posterior approach. So we know that one of the complications in total hip replacement is the higher dislocation rate, and we can address this to some extent by the surgical approach. There's a fierce argument about the use of bone cement in hip fracture surgery. It may increase the early mortality rate and undoubtedly has an effect on cardiac function. The clinical significance, the effect on cardiac function is unknown. However, cementless stems, if you want to avoid the use of bone cement, have a much higher revision rate, have increased pain scores as compared to cemented stems, and have a higher intraoperative femoral fracture rate. So you pay a price for using a non-cemented stem in hip fracture surgery. Increasing head size results in a decreasing dislocation rate in hip fracture surgery, just as it does in total hip replacement surgery for arthritis. But femoral neck fracture patients tend to have smaller diameter head and acetabular capacity than hip arthritis patients. So a combination of a small socket and a large diameter head will lead to thin polyethylene. The solutions are used in all poly cup to increase the thickness, use cross-linked polyethylene, or use these expensive metal or ceramic articulations. Wear may not be an issue in the older patient, but may be significant in the 65 to 70-year-old active patient who might have a 15 or 20-year life expectancy. Well, what's the current recommendation? Based on the literature and based on our practical experience where I work, we feel that undisplaced or stable fractures at any age should have reduction fixation or fixation alone with your implant of choice. Displaced fractures under age 60 or perhaps age 65 require reduction and fixation with your implant of choice, recognizing that they will have a significant high local complication rate. Displaced fractures in patients greater than 65 years of age we feel should be segmented into the minimal activity group, those who are living in like a nursing home where they are minimally mobile. These can be treated by a Moore or a Thompson prosthesis looking at the cost-benefit ratio. These are relatively inexpensive implants and can be used in a minimally active group of patients. Patients who are capable of moderate activity, what I call supported living, they may be living in a retirement home, should probably be treated with a cemented modular, monopolar, or bipolar prosthesis to maximize their function, minimize the complication rate. And finally, those patients with normal activity, patients who are living independently, doing their own shopping and so on, should be treated by a cemented total hip replacement with a large diameter head inserted through a stable surgical approach. This is still the unsolved fracture, but I feel we are getting closer. Thank you.
Thank you very much. The only one point what I feel should be added to enforce the discussion is if you are looking to the numbers of the patients who are dying until the end of the first year.
Right.
They are around 40%. It is a little bit higher than in the head-saving group.
Right.
That's the big difference. On the end, the number of infections. But we should push by side the infections. So what is really the difference if you are dying with a total hip or with a hemi-hip after 1 year? That's the only one point what I have to stress.
Well, that's a good question. It's a philosophical question, of course, but the overall mortality rate after hip fracture surgery varies, depending on the study and the country and so on. But if you actually look at studies that segment these patients out by pre-fracture morbidity, the very high mortality rate is actually due to those patients that are living in institutions or in some sort of supported living environment prior to their hip fracture. So that's why I'm saying that total hip replacement should be done in active, independent patients who have a relatively low mortality rate because they're relatively healthy prior to their fracture. And I think that all of us have had the experience of having to bring bipolar hip patients back at 5 years to revise their hip for a total hip. And I don't have that experience with the total hip replacement patients.
I think it is time to recognize that a discussion 10 years, 7 years ago, in this way how we are discussing the problem, have been impossible. Since all elective orthopedic surgeons have advocated total hip replacement and the trauma surgeons have advocated a hemi replacement. In the meantime, you can see very nicely the numbers from, for example, in the United States. The head sieving procedure is around 22-23%. The hemiprosthesis group is increasing in the last periods up to 70%, and only the rest, around 10%, is more and more decreasing, and the discussion is now more or less clearly closed. We should recognize that hemi replacement has a good place in the treatment of femoral neck fractures.
Right.
It depends only in which group of patients.
That's right, exactly correct. Yes?
Just one comment. It's a good paper, though it concerns arthroplasty. Raymaker, who has a wide experience of 30 years with intertrochanteric osteotomies, in a personal communication published in some journal, Scandinavian journal in 2006, has said that still efforts should be made to preserve the head of the femur by performing an intertrochanteric osteotomy and osteosynthesis of the neck of the femur, even in patients above 65 up to 70. He has said, after reviewing the literature, that 100% union with 6% avascular necrosis, as per literature, in patients, if you perform osteosynthesis and valgus type of intertrochanteric osteotomy. Age can be extended up to 70 years. Just one comment.
I have a point to discuss here in connection with this presentation, since we have built up two groups. One paper has employed himself with the head saving procedure, the other one with the endoprosthesis. In this case, everybody can tell you only that we have decided on to replace the head. So we cannot discuss about the group where we are not replacing the head. I think that's another topic.
Right. You know, I think everybody's experiences are slightly different, and I'm a firm believer in reduction and fixation of displaced femoral neck fractures myself. But the literature clearly shows that the results in displaced femoral neck fractures at 2 years is better in people with prosthetic replacement than people with reduction and fixation in terms of reoperation rate and pain scores. So.
Equation, the quality and quantity of the bone and the weight of the patient, particularly the former,
Right.
where fixation, however good, is unlikely to succeed.
I think really the reason that the reduction fixation is more successful in the younger patient is because they generally have better quality bone. And most of the young patients we see with femoral neck fractures have these fractures as a result of a fairly significant trauma, as opposed to the elderly patients who are almost all standing height, slip and fall accidents. So I think bone quality is a significant factor. But I must say, in our hospital, as a general rule of thumb, any patient with a hip fracture is osteoporotic. That's sort of the way we work, and then we investigate them for osteoporosis.
Thank you.
So, thank you very much, James.
Thank you.
We are running out of time. We should change now the team. We are speaking about now about trochanteric fractures, and Peter Bieberthaler from Munich will give his talk, sliding plate or intramedullary device.
Dear Chairman, ladies and gentlemen, we are now turning a little bit more laterally to the femoral neck, to the intertrochanteric fractures. And these are the aims I want to transfer in this talk. So I want to show you some principles of sliding plates, some principles of intramedullary nails concerning the means of transferring force from the hip to the femoral bone. After this, we will talk about some indications of both implants, and we will spend some words on surgery, placement, serums, etc. And then I will show you some cases, some good and some bad, and then some results in literature. All right. So what we heard now extensively is that in femoral neck fractures, the problem is more a nutritional one. This means that the blood supply is coming in over these arteries after this one is closed, and the femoral head is the blood supply of the femoral head is jeopardized by the fracture here. If you have intertrochanteric fracture, the problem is not so much a nutritional problem of the bone, but it's much more a stability problem, because the forces which are running through this part of the bone are very strong, and they try to pull all of this out. I will show you this later. So the dynamic hip screw has developed to take these forces and take them here into the femoral bone by this sliding mechanism. I'm sure you're all familiar with this. This is another sliding screw which has been developed before the dynamic hip screw, the dynamic compression screw. This screw principally is nice, but it has a biomechanical problem, which is depicted by the ankle of this screw, which is, if we go back, not so optimal adapted to the forces transferred into the femoral neck. So the usage of this screw has been reduced already, and it's almost not used anymore. So what are the biomechanical principles of the intramedullary nail? The forces are transferred into the screw and the nail, and they are a little bit better transferred into the femoral bone because they are transferred onto both sides. And this will have a great impact on the type of fractures we are operating on. So these are the indications for intramedullary nails. It's the unstable A2 fracture where you have minor trochanter dislocation, or especially the A3 type fractures. And I will show you nice cases on these type of fractures after this. So there have been various models of intramedullary nails. This is the Smith-Nephew nail. This is the gamma nail, which is the world market leader. And this is the Synthes model, this is the older model, and this is the newer one. And they all have a kind of similar way of transferring forces from the femoral head into the femoral bone. So now we heard a lot about the optimal therapeutic strategy of these type of patients. And this is a scheme I want to discuss with you, how we might be able to find this optimal therapeutic strategy for the individual. And the important thing about this is that these patients are mostly not young and healthy. They are not marathon runners. They are mostly elderly patients. So if we think about therapeutic strategies, we first must think about the injury, location, mechanism, soft tissue, and the bone quality. But we also have to think about the patient, age, risk factors, additional injuries. And then we must be aware how much function had the patient before this injury. And this will be the best we can achieve with our surgical procedure. And so these are the therapeutic factors. The experience of the surgeon, of course, and your facility and infrastructure. And then this will lead into the procedure, what you can do. So for intertrochanteric fractures, we have three main collective. We have a young, healthy patient after mostly a high energy impact, motorcycle accident, fall from height, working accidents. Then we have this golden age group, patients who are in between this group, 65, 75, and these patients have been in former days considered as elderly, but what we know now is that these patients do still have a very high physical activity, and they want this. They do not want to lose this physical activity. And then we have this third collective of the old and very old patients, mostly from nursery homes or something like that. So now we talk about indications of these type of implants, and I'm concentrating on the two major parts, on the dynamic hip screw and the intramedullary nail. If you have A1 type fractures, the biomechanical principle of transferring force from the femoral head, bone down here, is very nicely taken by the dynamic hip screw. And for these type of fractures, this implant is highly recommended. It's easy to implant. It forgives surgical failures if the residency during the night is not so experienced with it, in contrast to the 95 degrees condylar plate. And it will give you nice results. If you have A2 type fractures with a minor trochanter dislocation, it depends on the surgeon's experience and it depends on your facility options. Because if you have good options, if you have a traction table and an experienced nurse doing the night, then you might do a nail. If not, you're probably better off doing a dynamic hip screw. And in these type of fractures, A3 type of fractures, it's pretty clear if you implant a dynamic hip screw here, you will fail. I will show you this later. So we have been talking already about the extension table. If you do not have an extension table, you can use this type of positioning of the patient. So you have these, in fact, gynecological obstetric positioning supports. The important thing is that your C-arm will give you a two-plane image of your femoral head, like this in the lateral plane and like this in the AP plane. This is the important thing, and you can see with this kind of positioning, you can even get a good result without a traction table. Surgical technique for the dynamic hip screw, and we have been already talking about the optimal position of these 3 screws, and again, the optimal position of the dynamic hip screw is a little bit dorsal and a little bit caudal. This is something you're all familiar with. You drill this key wire and then you measure, and then you drill, and then you put your plate on. If you have trochanter dislocation, you can put in such a plate, and if there's instability, you can put in an anti-rotational screw. If you have a traction table, then you will be doing fine, because then you can have here adduction of the femoral bone, and this will help you with reduction. If you do intramedullary nail, preoperative planning is mandatory, because you must be sure that you have the right angle of the femoral screw to your individual patient. This is something very important, and all companies provide these kind of templates where you can plan your surgical procedure. After this, the entry point of the proximal femoral nail this is the Synthes product, is a little bit dorsally, and you see here opening the bone with the millimeters driller and then putting in the nail. These are some cases. So this is a male patient after traffic accident, and you can see this is a not too unstable situation. So in this situation, first you try to do reduction and then implement your dynamic hip screw, and this will give you a beautiful result. So this is a good case. Now comes another case. This was a 47-year-old heavy drinker, and he had this kind of fracture, which might be also identified as more or less stable. And the surgeon during the night put it in this screw. So what do you think about this? Are you happy with this? What would you do in the morning when you're the boss of the department, when you're responsible for trauma? Will you be happy? Who will be off? Who not? All right, I see. Why? Because the position of the screw is not optimal. It's too dorsally. And what happens if you put the screw too dorsally, you're all familiar with this, is that the femoral neck is just turning around this point like a screw or something around this. So the problem is, if the force is coming down here, it will turn around. So this is not the optimal position. And if you put in dynamic hip screw, please be aware that you have the correct position in the anterior-posterior position. Well, this is another case where the situation is much more unstable, and what I want to show you in this situation is that if you have minor trochanter dislocation, please do not just put in a dynamic hip screw without anti-rotational device, because this will fail. You can choose between an anti-rotational screw or like what has been done here with these type of circle arches around, or here additional trochanter fixation screws, but you need something which will prevent the head from rotation. This is something I want to give you. This is another case. where we had this kind of unstable situation, and again here was anti-rotational fixation using this circlage. And it's not so important that you fixate the minor trochanter. This will not bring you bad functional results. The important thing is that you have anti-rotational fixation down here. Okay, this is now a case where I want to show you how things will go bad. And you see this pretty unstable fracture. And as we learned already, this probably might be a good indication for a nail or even for primary anaprosthesis. Well, we tried to fixate it, and what happened is that here is a complete breakdown of the whole femoral neck, so we had to put in a anaprosthesis. This is another case. Now we come to the intramedullary nails. These are the A2 type fractures, and you can see this is a pretty unstable situation, and this is good solved putting in this intramedullary nail. The forces are transferred nicely here into the femoral bone, and even with bad osteoporosis, this type of fractures have a good chance to heal. Another case, even pretty unstable situation, and you can see again, well, this anti-rotational screw is a little bit high, but it has to be taken out, and you see already that the fracture has sintered, come together, but it healed nicely. So these are good cases. This is the pitfall I want to draw your attention to. If you try to fixate a A3 type fracture using a dynamic hip screw, it must fail. It cannot heal because the power is just transduced wrongly, and you will have pull out of your screws down here. So this is an example which happened. This is a pretty subtrochanteric fracture, and the surgeon tried to reduce it and put in this long dynamic hip screw, but reduction is not perfect and the position of the screw is wrong. So what happened is the whole thing fell apart, and what we have to do in this situation is this 95 condylar plate, which is, as a salvage procedure, a nice plate, but please be aware that you must really know very well, we have been discussing about this before, you must know very well where to put your initial drills in, because this plate does not forgive any kind of motion. If it's once the channel for the proximal blade is drilled, then the position is fixated. All right, so this is not a good idea, and I don't recommend to do this. Now, new developments of these kind of screws. There are several inventions of new blades. This kind of new blade has a better cutout, and there are more alternative modes of these screws, but they have only local meaning. So now we come back to our major collectives, and so the young, healthy, after high energy impact, he would be best off using an intramedullary nail. The golden ager with high functional demand will also be well off with an intramedullary nail because the function will be better. And the very old patient might receive a dynamic hip screw or primary anaprosthesis. So let me summarize my information. The sliding hip screw is a very well-established implant for A1 fractures. A2 and A3 fractures might be better treated using an intramedullary nail. Please check your guidance wires very carefully before you drill the big drillers, because after this correction is difficult. If you have more unstable fractures, please use anti-rotational devices to be sure that the forces are transferred correctly from the femoral head into the femoral bone. And if you have A3 type fractures, please do not use dynamic hip screw, it will fail. Thank you very much for your attention.
If you agree, I would like to invite at first Professor Schnettler to give his presentation, since your topic is already a transitory zone to his topic, the subtractures, and we can discuss them both on the end together.
Mr. Chairman, Vilmos, ladies and gentlemen, good morning. Indeed, mostly what I want to tell to you, you have heard in the previous lecture. But I think subtroch fractures, we are faced, trauma surgeon at least are faced monthly, very often, in our service. And I want to give you some of my own experience in the last 20 years about these fractures. And I want to discuss with you some good and some bad cases. And we have heard a lot of these fractures in the previous lecture. So far, proximal femoral fractures in elderly population are still a major public health problem and are associated with increased mortality, morbidity, and we have heard this from the previous lectures, very high healthcare costs. To make it brief, we have this classification. This classification works very good, and we differ between stable and unstable fractures. And so far, we know a lot of different implant designs, and we can, with these different implant designs, treat all these fractures. From the biomechanical point of view, intramedullary nailing devices are more stable, under loading, have a shorter lever arm, and are recommended for unstable proximal fractures, Mr. Bieberthal, 94. And as I told you, there are different nails, different osteosynthesis materials, but all these implants have typical complication. There's not one implant where I can say this is the best serve unstable or stable fractures. Some unstable proximal femoral fractures are assessed to be difficult to nail, also for experienced surgeons. We know, and we have in Europe, in Asia, and North America, patients with short skeletons, narrow femoral canals, adolescents with open physis, and patients with severe bowed or deformed femurs. And we have some demands as orthopedic trauma surgeons on modern osteosynthesis. Firstly, minimal invasive, immediate full weight for our patients, primary stability also in osteoporotic bone. More and more we see these older patients with these osteoporotic bone substance. Short operation time and also feasible by less experienced surgeons. It is a question because we are coming from teaching hospitals, so we have to teach these kind of operation. And we have a lot of demands for these implants. We have to respect vascularization. This is a work of my co-worker in the University Gießen. He performed this in anatomical studies with his vascularization, Dr. Meyer. And patients have a lot of demands. Early weight bearing, low invasivity regarding the soft tissues, low risk and low pain, low complication rate, one operation procedure. This is the demand of the patient, and short hospitalization time. What about the stability? I think that the stability is much more important than anatomical reconstruction. The main difficulties during operation procedures are varus deformity, undercurvation, wide medullary cavity, unstable fractures, difficult reduction in the operation area, and bad bone quality. As I mentioned before, reduction in bone mineral density is considered one of the major risks for femoral fractures, and you see here the reduction of the bone mineral density and what happens. I think you will go with me when I say mostly of this cutout is the surgeon fault, but more and more we see this reduction of bone minerality, and we see what happens either in nails or in plates DHC. Severe osteoporosis with thinner cortical bone of the femoral diaphysis is seen more often in patients with trochanteric fracture than in patients with femoral neck fracture. A previous paper I citate here. And I want to discuss with you mistakes and dangers. First, the wrong entry point. All these happened in my hospital. as we are a teaching hospital. The approach we have seen in the previous lecture is very important, a little bit above the trochanter, the great trochanter, and a little bit dorsal, as you see it here, and see it on this NMR slice. So, one very bad case, mostly in the evening, performed in my own hospital. You see absolutely a wrong entry point with this long static gamma nail, and this very bad reposition. So we took away this nail and put in this Crosser-Kempf nail. It won't work because the nail, 30 millimeter nail, is too weak for this because you have here a very bad reduction. So I take away the nail. The nail was broken after, I think, 10, 12 days. I took away this nail and performed by myself a static osteosynthesis with this gamma nail. And after some weeks, we performed a dynamization, and nature healed this comminuted fracture, as you've seen in these slides. Most important is the good entry point, and not to take a wrong point, bad reposition. What about this? You see it here in reverse fraction. Don't treat this patients with a closed manner of operation. You have to open this, as you see it in the next unstable fracture. Put in a long nail, despite of gamma or PFN or other devices, and make an open reduction and fix it with a cerclage. What about the ventral impingement in strong undercurvation? You have to take this before you start your operation in consider, respect this undercurvation, and here you see not a good result after nailing a subtroch fracture. And in the early beginning, I remember very well, in 89, 90, I think, when we started with these short gamma nails, we have seen, and I have seen in my department in Frankfurt at this time, a lot of shaft fractures. You see one case. You see on the distal part of this nail a fracture. And then it's a very good choice to make this procedure with a long gamma nail, and it will heal. But sometimes, due to osteoporotic situation, after another accident, you will have fractures here. What to do? So the fracture is healed, put away this nail, and make a retrograde nail. But we are talking about complication. Look here. So another fracture appeared, but you can easily manage this, took away this nail, and bring in a long retrograde nail, and fracture will heal. But you know that you must have experience with this. The indication, as we have heard it before are extensive subtroch, intertrochanteric, and pertrochanteric fractures reaching in the femoral diaphysis. And this is a case with a broken spiral plate. You remove this, and you see the broken spiral plate in this case, and we treat this with a long nail, and we saw a very good bony consolidation after 1 year. What about reduction with a gap? Might be very risky. So if you give your patient to a reduction table, before you start your operation with these long nails, make an excellent reduction. And here you see nature will heal it after dynamization and full weight bearing. It healed. This is the 3-segmental fracture. It's ideal for a long nail. And you see here the bony healing after static nailing and heart implant removal. What about these fractures? These are not. These is a young patient, traffic trauma, polytraumatized, And I was not happy when I saw this in the early morning round because the nail is too short. But as I said, it is a very good reduction, and we will keep it, and we will see what happened. And you see what happened. It's a very good healing, and this is the patient, without any pain, without any loss of range of movement. This is a polytraumatized patient, and this is an ideal indication for nailing. We just made this some month, 7-8 months before, and here it is very important. This is the gamma 3 nail. It's very important to choose the right entry point. And Vimosh, you see, this is our nail we developed, an unreamed nail I put in. And after 6 months, you see a very good bony consolidation in the subtrochanteric area and in the tibial area. And by the way, as Dr. Bieberthaler mentioned, this is very important to have a very good placement of this screw. So, main problems at the proximal femur region are the cutting out of the leg screw, non-union, implant failure, and screw loosening. You have to take all these into your consideration, and this is not not fractures for unexperienced surgeons. And the conclusion of my short talk is intramedullary nails act as central load carrier and exhibit the best preconditions for fast, positive, full weight bearing in the case of subtroch fractures. Greetings from my staff. Thank you very much.
Thank you very much. Now, both papers are open for discussion. Please come up, Dr. Bieberthaler. Are there any remarks? James?
I like that idea of the cerclage wire in the oblique proximal fracture, and I use that myself. But in our fracture conference, there's always an argument about whether you should take the wire out after you've fixed the fracture.
Yeah.
Because of
James, I know this because the wire will
the blood supply. Yeah.
compromise the blood supply because for the perios. But I leave it.
You leave it.
Yeah.
Okay.
So, you are the next.
I want to ask both of them, when do you allow, especially in the old age, weight bearing after the DHS and the gamma nail? When to start?
Well, as you know, these type of patients, the compliance of these type of patients is not always the best. So what we try to tell them that they should keep 6 weeks, not more than 20 kilos. But in reality, the fact is that most of them give much more weight on this. So this is a player for devices who are able to transfer the forces as optimal as possible, such as intramedullary.
So you allow immediate weight bearing?
No, we don't allow, but the fact is
the reality shows you we allow it in both cases. Immediate weight bearing, complete weight bearing after the second day after the surgery.
Also in comminuted fractures?
Absolutely, yes.
Yeah. Yes.
Because depends on the pain. Depends on the pain of the patient. But the earlier, the better.
I heard Professor Zuckerman from the American Academy speaking, saying the same thing. Allow even in comminuted fractures immediate weight bearing. 2 days after, I had a patient, 80-year-old, that had a comminuted fracture treated by DHS. Perfect position, perfect alignment of the screw and everything that you want, and it collapsed and the fracture displaced. So I decided to check again it.
Yes. Everybody has exceptional cases, but as a rule, 95 to 97% of these patients are allowed to put weight on.
If
as older as more complete.
If the situation is preoperatively already completely catastrophic and the patient is old, probably one might think about a long shaft primary bipolar endoprosthesis or something like that.
One comment. Vilmos and myself, we know very well a colleague coming from Haifa, and he developed a plate, a sliding plate, for
Gottfried, yeah.
And we met in. And last time when we have been in your orthopedic community in Tel Aviv 2 years before, I met him the last time, and just we discussed this. And I tell you what he told me: as early as possible weight bearing after osteosynthesis with his Gottfried plate.
Sorry, you are the next, please.
Yes. One question: what's your recommendation of the positioning of the screw? And the IP view, central or caudal?
Both.
Both
in the lateral position, it should be central.
And in the AP view?
In the AP view,
It's
you might
caudal?
a little bit caudal.
A little bit caudal.
Yeah.
Not central.
No.
That is for the femoral neck fractures.
No. Talking about subtrochanteric fracture and
A little
intertrochanteric
bit caudal,
fracture.
so you can put in an anti-rotational screw above.
So you recommended is caudal.
Yeah.
Is this recommendation evidence-based, or is it just your opinion?
They are, I can tell you, 3 papers which seems to be evidence-based, and they are contradictory. All 3 are contradictory. So the clinical use shows you that the best position is a little bit caudal of the center.
I think evidence-based medicine is an excellent thing, but we are talking about our own experience. But there are some works, some histological works, cross-sections of the femoral head concerning the mineral density and the quality of bone, and in the caudal part of this bone, of the head, you will have the best quality, and so you have the minor risk for a cutout of the leg screw.
Asking Professor Schneider, which level that you advise to change from the short one to the long intramedullary nail fixation for subtrochanteric fractures? Like a short gamma nail to long gamma nail. Which level that you...
where the fracture is situated,
right.
if you are choosing a short or a long one.
Absolutely the same he mentioned before. In undisplaced petrochanteric fractures and DHS, absolutely, this is the best choice you can make. And in unstable fractures and subtroch fractures, always in subtroch fractures, a long nail, not a short nail. And in petrochanteric fractures, unstable, I discuss it. I look very, very seriously in the X-rays, and then I discuss it. But more and more a long nail.
The last one, can I?
Yes.
Yeah. Okay.
You do it in Thailand also?
Okay. When we've faced with the coronal splitting fractures at the trochanters, what is your solution to solve this problem during fixations? The splitting of the coronal plane.
Yeah, you must somehow fixate it, either using circlage, screws, something. You must, because if you don't fixate it, the muscle force will pull the major trochanter away.
Thank you.
So, the last.
I've got 2 questions. The first one is that I saw all the pictures, the comminuted proximal femoral fractures, treated with nails. You have done only one distal locking, only one screw, the distal locking. Do you suggest the 2 screws be done, or only one is enough?
Well, this depends a little bit on the bone quality. If you have the cases I showed it was a young male patient with very good bone quality, so 1 screw was enough. If you have bad bone quality, 2 screws are better.
Thank you.
I think the question is not so much if, may I correct you a little bit, or support you as well at the same time. If you have the feeling you should use 2 screws because the fracture is comminuted or very near locking side, use a longer nail. But lock a short nail only once. We have given up since 1999 to lock twice the short nail. If it was needed to lock it twice, use a long nail.
The second question is that if you have got a young active male with a grossly comminuted distal and proximal femoral fractures, having a good area in the proximal segment, what about your idea about bridge plating? Bridge plating.
You mean ankle stable plate?
Yeah.
Well, this is something which is always being brought up in this type of discussions, and everybody of us has 1 or 2 cases where he tried it. The problem is that the forces which are transferred through the femoral head into this ankle stable plate are too high to not prevent that the screws will break. There are several attempts using polyaxial or monoaxial ankle stable plates in doing this, but the results are not very good. So to my experience, we tried it and we get away again.
Thank you.
I think there is a last
One comment.
Sorry, yeah.
One comment, sir. Concerning your question about the screws distal, I want to make one comment. I remember, when you asked this, I remember some cases done, I have these X-rays done by Professor Küncher himself with his first nail. He demonstrated this nail. I'm sorry?
The tensor.
Yeah. He demonstrated this nail in the 60s, I think, in the 60s.
86.
Yeah, 80s, yeah, of the last century. And this is the so-called detention nail. It was, so far as I remember, the first interlock I have seen, at least in Europe. He developed this nail for management for open fractures. And he used one screw. And I remember some cases, X-rays. What happened with this one screw? You won't have a rotational stability. And we have seen, when we do this as a young assistant, I saw this, with these cases, we saw osteolytic areas there. And then the development starts, and I remember very well, and you too, I think, the first interlocking nail with 4 screws, distal screws. It's not good, but because of the rotational stability, they used 4 screws, but I think 2 screws is excellent. You have absolute stability.
So the last.
Thorab Said from United Kingdom. My question is, you said the screw should be placed in DHS, a bit caudal, but the paper from America, the tip apex distance, and we are taught traditionally in my unit at least that on AP, the screw should be in the center, and it should be in the center on the lateral as well, but you say it should be caudal, so does that increase the tip apex distance and increase the cutout?
Well, this is the discussion we had already before. The problem is that if you have the dynamic hip screw, the central big dynamic hip screw, if you have it too high, it's very difficult to get an anti-rotational screw above, first, and second, the way of the top of the femoral head to the screw is very short, so you have a higher cutout rate. In this respect, I would recommend that you do a little bit lower position in the AP view and put in another anti-rotational screw above, so you overcome this problem of turning of the femoral head.
Thank you, but doesn't that increase your tip apex distance if you put it caudally? The
Pardon?
apex, the distance from the tip of the screw to the apex of the head, doesn't that distance become increased when you do that?
Well, you shorten the anti-rotational screw must be 1 centimeter shorter than your central dynamic hip screw. So you have in your X-ray you have a plane between both tip of the screws.
Thank you.
Thank you, Mr. Chairman. Peter, you are talking of anti-rotation screw in unstable fractures. You are talking of anti-rotation screw in unstable fractures. So this screw is generally used floating. It is a 3-part or 4-part fracture. It is unstable. Whenever you put this screw, it is floating. It is not serving any purpose.
So I think we should finish the discussion. I'm very sorry. Thank you, the others, presenters, and you that you came so early in the morning to this session. And I hope you have enjoyed it like myself. Thank you.